If we go into more detail, we would know about the term spondylolisthesis, okay? And for spondylolisthesis, you have to know what that term actually means. So the definition literally means spondylo means of the spine, and listhesis means slippage. Go ahead, Owen. Put your hand down and go ahead.
Yeah, I was just wondering how often these conditions occur together, if ever, or are they very different?
No, this is, even though I put these as separate things in the textbook, I wanted people to realize lumbar instability doesn't have to be a full-blown spondylolisthesis. It doesn't have to be where the vertebrae actually slides, okay? So this is just going to be a higher end on the spectrum right here. And we're going to see what the grading system is here in a little bit, and I'll show you all this stuff with the imaging.
Okay, perfect. Thank you.
Yep. All right. And I mean, the problem with low back cases, it's a good question, Owen. The problem with low back cases are a lot of these conditions coexist. What? You mean I could have a lumbar sprain strain with DJD, with spondylolisthesis, and a nerve root compression all at the same time? Absolutely, you can. And it makes for very difficult cases. This isn't like typical shoulder or hip or knee injuries where it's pretty obvious what's going on and you can figure it out pretty easily. In these cases, it's really a lot of detective work and finding out what works specifically for that individual patient is the tricky thing. Okay. All right. So what are we looking at here? Spondylolisthesis means spondylospine, listhesis, slippage of or sliding of. If you are down with your lingo, if you want to hook up with the radiologist, you can say, oh yeah, we got a grade 4 spondy, L5S1. Okay. Spondy is the terminology that's used in radiology typically. But what you get is a pars interarticularis defect. And where is the pars interarticularis? It is this area in between the zygapophyseal joints at the back. There's lots of variations of how these spondylolisthesis can occur. And there's a whole bunch of classifications of them. There's dysplastic, where you actually have a defect in the neural arch. There's isthmic, where you can have lytic, where it actually breaks, and that's a fracture. You can be congenitally born with a longer pedicle reaching out a little bit further. You can have an acute pars fracture. You can have degenerative changes that lead to it. You can have a traumatic fracture or a pathologic fracture secondary to metastasis or Paget's disease or other conditions as well. At the end of the day, don't worry about all the different types. The person, this is from McNabb, the person actually has a instability, a significant instability. Prevalence is actually quite common. It is 5 to 7% of the Caucasian populations and up to 40% of Inuit populations, okay, or Northern Canadian populations, whatever you want to say. All right, mostly L5S1 and sometimes L4, L5. They do happen rarely in the cervical spine. They're usually secondary to like some kind of ligament laxity, secondary to a congenital defect like Marfan's or rheumatoid arthritis. Generally more common in females than males. In general, women tend to be more flexible than females, more flexible than males. There may be a familial predisposition. And again, the risk factor here, where I have seen it in practice in particular, is in gymnasts and rowers, okay? Especially female rowing teams where you start like in your 18, 19, 20. That's a lot of, the spine is just finished growing. That's a lot of stress on the low back, okay? Deadlifts potentially as well. All right. So a powerlifting champion of Ontario, and he actually had, significant spondylolisthesis right there. Okay, so what do you get? You get low back pain. Go figure. That radiates down into the buttocks, but does not go past the knee. If the pain goes past the knee, what are you thinking? Yeah, you're thinking radiculopathy, nerve root compression, okay? Little or no correlation between slippage and clinical presentation of pain. So just because somebody has a ton of slippage doesn't mean they're going to have a lot of pain. And just because somebody's got a little bit of slippage doesn't mean they're going to have little pain, all right? This powerlifting champion of Ontario, he had a grade 4 spondylolisthesis, traumatic secondary to fracture from lifting in the 70s. And he had just a really tight low back. He said, yeah, my back's bugging me a little bit, but it's not too bad. And I looked at his spine. It looked like typically you'd see somebody with a spine like that and you'd wonder, how can this person walk? Of course, I did not say that to him at all, but it was just like, he actually had a compression fracture where one vertebrae, L3 literally dropped into L4 and compressed halfway into the vertebral body. Like it was just crazy. All right, increased pain with weight-bearing extension especially. Pain is reduced with lumbar flexion or laying down typically. And there may be stenosis signs in geriatric patient populations as well. So inspection, possible lumbar hyperlordosis, may walk with the knees slightly bent or rigid lumbar spine. They're just trying to stabilize the area and take some stress off of it. Hypertonic low back and hamstring muscles. If somebody comes in and their low back is like rocks, their hamstrings are like rocks, this goes up higher on my list. And you might actually see the SP at the level more prominent. We can call this a step defect potentially. When you're doing motion, you might see a repeatable click every time they move. Click, 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 every time they do flexion extension. Neurovascular is within normal limits unless they have nerve compression, which may be there in approximately 30% of patients, but usually this nerve compression should be bilateral, okay? Usually you don't see a unilateral compression. Cauda equina syndrome has to be a big differential with bilateral lumbar nerve compression. Lumbar disc herniation should usually be unilateral in a dermatomal distribution, right? Sprain strain should be only associated with not neurologic symptoms, but just local pain and tenderness with palpation and loading and challenge of the tissue. Facet syndrome, local pain worse with extension, and lumbar DJD osteoarthritis. Yeah, pain that's worse in the morning. Stiffness first thing in the morning. Can't really move that well. Loosen up as I move around for 20 minutes. Worse at the end of the day. You can also feel storms coming and crepitus with motion, and look for it on X-ray as the confirmatory diagnosis. Special tests for instability. Segmental instability test is phantasmagorical. Okay. Push on those SPs as the person's laying prone. See if one of them slides a little bit further than another one. If it does and they have local pain, have them lift their legs up, engage the erector spinae, stabilize that low back, push a second time, and see what's going on there. Remember that we have the videos of these tests as well. X-ray is the primary mode of diagnosis, and I need you all to know the Meyerding grading system for it. It is really simple once you get it, but there's a couple of key things we have to get. So number one, looking on X-ray, there's this sign of the Scotty dog that you're going to be looking for. So if you look at an oblique view of the lumbar spine, and that's what this is, I'll outline a vertebral body right here. This is going to be a zygapophyseal joint, and this is going to be the Scotty dog right there. And I've taken the time to draw them out separately right here. This is an intact Scotty dog. You can see its neck and collar and everything is fine. But if the neck breaks or if there is a collar around the Scotty dog, that indicates a fracture in the lumbar spine. Now, this one is not such a big deal because chances are you're going to have a radiologist look at this for you and give you the actual diagnosis. But the one that you really want to pay attention to is this Meyerding grading system. How far does that vertebrae slide forward? And it's a scale from 0 to 5, and each grade is a 25% slide. So if it's a grade 1, it could be anywhere from 0 to 25%. Grade 2, 25 to 50. Grade 3, 50 to 75. Grade 4, 75 to 100. And if you are at 100% slippage, you are into this grade 5 on the Meyerding scale, which is a spondylolisthesis, where the whole spine actually slides right off of the sacrum. And that is significant instability right there. Even this one that I chose to take a picture of right here is a grade 4 spondylolisthesis. This person would have significant instability right here. If they're doing flexion extension, imagine this vertebrae sliding all the way back, sliding all the way forward, significant injury. And in fact, the thing for this person that's disappointing is look at how good these discs look. That's a pretty good looking disc, nice and juicy, little bulge, still pretty juicy, a lot of nucleus pulposus right there. But you can see a little bulge right there, but you can see this next disc right here, L5S1, is just shredded up for this person. So now imagine going to pick up any weight, going to move anything where you have to lift and move your body or twist. This is going to cause significant issues for this person. Can I guarantee how much pain they have? Nope, absolutely not. Do they probably have low back pain? I would almost guarantee it. Okay, almost guarantee it. And they're looking at spinal nerve root compression right here at the back of the sacrum as this slides forward. So not a pretty picture right there for that person. All right, so number one, treatment management options for this patient. Have them recognize what the condition is and your ability to help. Give them that biopsychosocial support recognizing this condition. Goal is to reduce load on the discs and build up strengthening into a more neutral position of the spine. And again, back for Parsa right here, corsets and braces are going to be huge, okay? All right, slightly flexed or neutral, maybe unloading the facets a little bit. Non-weight bearing activities are going to be good for this person. Get them swimming, flexing, extending their spine. Massage therapy, muscle hypertonicity may help provide increased stability. Do not loosen this person right up. try and decompress their spine, but maintain that functional stability as they flex and extend or laterally flex their spine. Joint mobilizations should not be directed directly at the segment. Generally, you want to go with the segments above or below to reduce stress on the unstable segments if possible. Surgery can be required, especially in more severe cases where you can have surgical pinning taking place with plates or wires to hold them in place. Okay. All right. What am I going to do for follow-up? Conditioning and proprioceptive retraining. We've got to get you to move in a safe way and get your body to do that naturally. So strengthening of back and abdominal musculature and trying to do it without excessive compression, such as in a pool, is huge. Okay. Younger patients will have a higher risk of progression for these congenital types. So you want to definitely warn them of that and give them recommendations for exercises based on that. Follow-up x-rays typically every 6 months on these people. Prevention, avoid repetitive hyperextension activities. If you are rowing, I am sorry, you just can't row as hard as you want to in this. We have to look at different activities for you here, okay? I actually see this in yoga practitioners as well. Upward facing dog can put a lot of stress into the low back, into hyperextension. Most spondylolisthesis, like grade 1, grade 2, respond extremely well to conservative management. You can deal with this, Julia, in your clinic, okay? You'll have no problem with this in your clinic. The more significant ones, though, you should absolutely be looking at surgical consultations with this. Do not take the risk on yourself. Really see what you can do with this person, especially if there are any neurocompressive disorders taking place with that. All right. And then just like we did in class last day, one of the simple exercises you can do is just going to be a nice bird dog exercise right here. Okay. Our quadruped track. Again, looking for them to be able to maintain their spinal position and then eventually progressing into increasing strengthening exercises from there, which of course we have all kinds of videos and handouts that you can give to patients on our website and in our textbooks. All right. Questions on that?
I was wondering if there is neurovascular symptoms, do they mimic like a lumbar radiculopathy, but they're bilateral?
Okay, so that is a great question. So the question is, do they mimic a lumbar radiculopathy, but they're bilateral? I'm going to change it. We'll wait until we get to the next things right here as far as stenosis goes, okay? We're going to talk about stenosis and cauda equina syndrome. If it was a lumbar radiculopathy secondary to a disc herniation, the main differential would be that it is caused by coughing, sneezing, and straining to make it worse. In a spondylolisthesis, you will not see that, okay? If I cough, unless I had a coexisting compression as well, it's not going to change how this happens. The big differential here, back to our DDX list for spondylolisthesis, is this a cauda equina syndrome is what you're going to be looking at. Okay. And once you guys see this, you'll be able to tell them apart, no problem, because one is a medical emergency. We'll look at the stenosis too. It can be a little bit trickier. Typically, yeah, you just got to wait until I get into it a little bit more before you get this fully, but it's a good question.